Hello, my name is Brittany Petersen, and I'm going to discuss the neuromuscular blockade reversal agent Sugammadex. Muscle relaxants are commonly used in anesthesia practice to facilitate endotracheal intubation and improve surgical access by preventing reflex muscle movement from surgical stimuli. In order to prevent postoperative complications from residual muscle weakness, reversal agents should be given to terminate the effects of muscle relaxation. The only reversal agents available for use were anticholinesterase agents until the recent development of a selective relaxant binding agent, Sugammadex. Neuromuscular blocking agents are classified as either depolarizing or non-depolarizing, and each have differing mechanisms of action. Succinylcholine is the only depolarizing agent and produces prolonged depolarization of nicotinic acetylcholine receptors on motor end plates, which lead to membrane hyperpolarization. Succinylcholine is metabolized by plasmacholinesterase. Since anticholinesterase agents significantly decrease plasma cholinesterase activity, they should not be given after succinylcholine administration, or there will be a prolongation of neuromuscular block. Non-depolarizing neuromuscular blocking agents are competitive antagonists at the nicotinic acetylcholine receptors on motor end plates. These drugs will bind to the nicotinic acetylcholine receptors but will not activate the receptor, which prevents muscle contraction. Non-depolarizing neuromuscular blocking agents are further subdivided into benzoyl-quinoliniums and steroidals. Anticholinesterase agents can reverse both types of non-depolarizing neuromuscular blocking agents, while Sugammadex can only reverse steroidal non-depolarizing neuromuscular blocking agents. Appropriately terminating the effects of a neuromuscular blockade before extubation at the end of a procedure is important for patient safety. Without doing so, the patient is at risk for aspiration, compromised ventilation, and other pulmonary complications. Neuromuscular monitoring must be performed throughout the case when there is administration of a neuromuscular blocking agent. Such devices include train of 4, single twitch, and tetanic stimulation. Based on twitch response to electrical stimulation from neuromuscular monitoring devices, qualitative or quantitative information, such as presence of fade or train of 4 ratio, is provided to assess the degree of residual block. Depending on the depth of the block and signs of or lack of recovery, this will guide the plan of care and dosing of reversal agents. Neostigmine, edrophonium, and phytostigmine are the anticholinesterase agents currently used in practice, with neostigmine being the most common. Anticholinesterase agents reverse the effects and accelerate recovery from non-depolarizing neuromuscular blocking agents by inhibiting acetylcholinesterase from breaking down acetylcholine. Inhibition of acetylcholinesterase causes an increase in acetylcholine in the neuromuscular junction. Acetylcholine molecules can then compete with the non-depolarizing neuromuscular blocking agent molecules for binding at postsynaptic nicotinic acetylcholine receptors. Activation of nicotinic acetylcholine receptors on a motor end plate occurs by the binding of two acetylcholine molecules to the receptor, which causes muscle contraction. The effects of anticholinesterase agents are not specific to nicotinic acetylcholine receptors. Acetylcholine stimulates muscarinic acetylcholine receptors, and the increase in acetylcholine from anticholinesterase agents will cause stimulation to muscarinic acetylcholine receptors as well. Adverse effects of muscarinic acetylcholine receptor stimulation include bradycardia, hypotension, increased salivation, nausea, vomiting, abdominal cramps, diarrhea, and bronchoconstriction. It is vital to administer an antimuscarinic agent, and they are also known as an anticholinergic. This will counteract these adverse effects, although these drugs come with their own adverse effects, which include tachycardia, blurred vision, and dry mouth. Other disadvantages with the use of anticholinesterase agents are a ceiling effect, need for signs of neuromuscular recovery before these agents can be given, and muscle weakness can occur if given after recovery from neuromuscular blockade, which resembles a depolarizing block. Anticholinesterase agents are not the most ideal reversal agent to neuromuscular blockade. Research done by the scientist Anton Baum led to the discovery of Sugammadex, also known as ORG-25969 in investigational studies. The brand name of Sugammadex is Bridion, which is marketed by Merck & Company Incorporation. Sugammadex is a modified gamma cyclodextrin and has a three-dimensional shape resembling a donut. The hollow cavity is hydrophobic with a lipophobic exterior. Sugammadex terminates the effects of steroidal non-depolarizing neuromuscular blocking agents by means of encapsulation. Encapsulation causes the steroidal non-depolarizing neuromuscular blocking agent molecule to be inactive. The inactivation of steroidal non-depolarizing neuromuscular blocking agent molecules creates a concentration gradient favoring the movement of the steroidal non-depolarizing neuromuscular blocking agent molecules from the neuromuscular junction into the plasma, where they continue to be encapsulated by free Sugammadex molecules. The three steroidal non-depolarizing neuromuscular blocking agents currently in use are rocuronium, vecuronium, and pancuronium. The binding affinity of Sugammadex to each of these steroidal non-depolarizing neuromuscular blocking agents differs. There is some binding affinity of Sugammadex to pancuronium, but it is so little that it doesn't have a significant clinical effect. The binding affinity of Sugammadex to vecuronium is high enough to form tight complexes, but not to the degree with rocuronium. Sugammadex forms very tight complexes with rocuronium at a 1:1 ratio. The Sugammadex-rocuronium complex has such a low dissociation rate that for every 30 million Sugammadex-rocuronium complexes, only one complex will dissociate. Since Sugammadex only encapsulates steroidal non-depolarizing neuromuscular blocking agents to render them inactive, Sugammadex is contraindicated for reversal of succinylcholine and benzyl isoquinoline non-depolarizing neuromuscular blocking agents. Sugammadex can't be given to patients with a known anaphylactic reaction to the drug. Another contraindication of this drug is for patients on dialysis or with a creatinine clearance or a glomerular filtration rate of less than 30 milliliters per minute due to Sugammadex's elimination primarily through the urine as well as the guest host complexes. Sugammadex is physically incompatible with ondansetron, ranitidine, and verapamil. These medications should not be combined. Sugammadex has no effect on acetylcholinesterase or any receptor system in the body, but it can interact with other molecules. Sugammadex interacts with hormonal contraceptives and renders them ineffective for 7 days, and patients should be advised of other birth control options. Sugammadex has a higher affinity for teremethine, fusidic acid, and flucloxacillin, which can displace rocuronium and vecuronium from the complex with Sugammadex. Displacement of rocuronium and vecuronium can result in reoccurrence of neuromuscular blockade. Another side effect is bradycardia and can occur within minutes after administration of Sugammadex and is best treated with atropine. Other side effects include hypotension, headache, nausea, vomiting, dry mouth, decreased temperature, and signs of emergence such as moving, sucking, and chewing. Sugammadex has a high affinity for bone and tooth enamel, resulting in drug deposits. Prothrombin time and partial thromboplastin time can initially have a small increase, but is self-resolved within an hour. Despite transient increases in PT and PTT, there were no differences in bleeding or anemia incidents in studies. A major benefit of Sugammadex over anticholinesterase agents is that it can reverse shallow or profound neuromuscular blockade from steroidal non-depolarizing neuromuscular blocking agents. When using rocuronium, terminating the effects of this drug can occur at any time, even immediately after administration. Deep levels of neuromuscular blockade can be maintained until the end of surgery. Neuromuscular monitoring provides information to assess the depth of neuromuscular blockade, which is relative to the dosing of Sugammadex. When appropriate doses of Sugammadex are administered proportionately to the depth of neuromuscular blockade, residual curarization will not occur. If the train of 4 count is 2, the appropriate dose of Sugammadex is 2 milligrams per kilogram given intravenously. When there is no response to train of 4, but the post-tetanic count is 1 to 2, the appropriate dose of Sugammadex is 4 milligrams per kilogram IV. If rocuronium is needed to be reversed immediately after administration, the appropriate dose of Sugammadex is 16 milligrams per kilogram IV. These doses are for adults and children 2 to 17 years old. The use of Sugammadex in pediatric patients less than 2 years old is limited and should not be used until future studies can confirm efficacy and safety. The elderly exhibit a slower recovery from reversal of neuromuscular blockade and is thought to be related to a decrease in cardiac output. No adjustments in the dose are needed for this patient population. When neuromuscular blockade is needed within 24 hours after a dose of Sugammadex, it is recommended to use a neuromuscular blocking agent that is not from the steroidal class. This is related to the maximum clearance of Sugammadex. There are no negative effects on pregnancy, embryonic, fetal, or postnatal development. Sugammadex can be safely given to patients with cardiovascular and pulmonary comorbidities. Use of Sugammadex is recommended over anticholinesterase agents for patients with neuromuscular disorders due to less risk of residual curarization. Sugammadex is pioneering the reversal of neuromuscular blockade. With Sugammadex's close to ideal pharmacological profile, there is the potential for greater use of rocuronium and the falling out of other neuromuscular blocking agents. Neuromuscular monitoring is crucial for dosing of this drug, and future improvements of these devices may be seen to increase accuracy of dosing. Future studies of Sugammadex are needed with the focus on efficacy and safety in children and infants and cost of reversal with use of Sugammadex versus traditional reversal agents. Sugammadex is truly a great addition to the armamentarium for reversal of neuromuscular blockade.